All right, we'll get started. Good afternoon, everyone, and thank you for joining us today for the 2022 ANZ-Melbourne Institute Health Sector Report launch. My name is Cindy Arthur, and I am the Acting Head of Health for the ANZ Commercial Division. Before we begin, I would like to acknowledge the traditional custodians of the land on which we all meet today. I personally am on Gadigal land of the Eora Nation. I would like to pay my respects to elders past, present and emerging, and extend those respects to Aboriginals and Torres Strait Islanders joining us today. We are very excited to launch the latest ANZ-Melbourne Institute Health Sector Report called Trends in the Structure and Financial Health of Private Medical Practices in Australia. This is the sixth in the line of reports which ANZ have collaborated with the Melbourne Institute on, and I am personally very proud to be a part of this partnership, as it shows our continued commitment and support of the medical industry here in Australia. In today's event, Professor Anthony Scott from the Melbourne Institute Applied Economic and Social Research Department will present findings from prominent researchers and experts in the field, looking at how private medical practices have been impacted by the recent pressures caused by the COVID-19 pandemic, the financial health of the sector, and what the trends and implications of these are on cost, quality, and access to care. Before I introduce our speakers today, let me remind you of a few housekeeping matters for this event. This webinar is being recorded. We have asked Anthony to deliver his presentation. He will speak for approximately 25 minutes. Following Anthony, we will ask our panelists, Julia O'Reilly and Dr. Michael Wright, to comment and provide their insights. To handle questions and comments, we're relying on the Q&A function found at the bottom of your screen. You can submit questions at any time through this function, and I will aim to ask as many as possible in the question and answer time. Please vote up the ones that you would like me to ask in the first instance. I would like to now introduce our speakers. Professor Anthony Scott is the Health and Healthcare Program Coordinator at the Melbourne Institute. He is a Fellow of the Academy of the Social Sciences in Australia, the immediate past President of the Australian Health Economics Society, and a Board Director of the International Health Economics Association. He established the Medicine in Australia Balancing Employment and Life, which is called the MABEL Panel Survey of 10,000 doctors, and is a research lead investigator in the NHMRC Partnership Centre on Health System Sustainability. Before I hand over to Tony, I would also like to introduce Julia O'Reilly. Julie is a director in the Business Advisory Division of William Buck, Australia. Having gained a wealth of knowledge and experience working for accounting firms in Brisbane, Sydney, and New Zealand, Julie provides meaningful advice on general tax and strategic business planning, including establishment, structuring, asset protection, and growth strategies. Julie has specialized knowledge in relation to the medical and dental industries, covering all areas of general and specialist practice, as she has assisted them with accounting, tax, and business advisory requirements. We are also joined today by Dr. Michael Wright, who wears many hats, namely as a GP, health economist, and health systems leader. Dr. Wright works as a portfolio GP, combining clinical practice in Sydney with academic research and strategic appointments. He is also the Chief Medical Officer of Avant Mutual, Australia's largest medical indemnity provider, and has appointments with RACGP, the Central and Eastern Sydney Primary Health Network, the Australian Institute of Health and Welfare, and New South Wales Health Agency for Clinical Innovation. As you can see, we have a lot of experience in our panel today. So please join me in welcoming our guests, and I would now like to hand over to Professor Anthony Scott.
Thank you, Cindy, and welcome everybody today. I'll just share my screen to start. Okay, hopefully everybody can see that. Look, it's great to be here today and share some new research from some new data. I always get very excited when I have new data to present. And this is an important area, one which is not talked about that much, but which a bit of data can actually go a long way in the current debate. So it's been really good to kind of continue this partnership with ANZ, who've been very supportive and obviously, you know, this report does go a long way to try and address issues of public policy, as well as issues related to the health of the private medical sector in Australia. What I want to do is just first of all go through a few of the key issues affecting private medical practices in the last few years, and there have been a few, as we know. There's continuing growth in doctors' numbers and increasing competition, particularly for non-GP specialists. The numbers of GPs, we know there's an issue, a really important issue there with trying to recruit enough GPs, but certainly other specialists or the numbers are growing much faster than GPs, and that increases competition. We've had the pandemic, of course, which was affected pretty much everything in all aspects of our lives, and we'll be looking at that as part of this. We've also had the Medicare fee freeze, where the indexation for Medicare rebates was frozen for kind of 4 to 5 years, which again, reduced public funding essentially to the private medical sector during that time period. We've also had, before COVID, if you remember, the fall in private health insurance membership, which also led to a fall in the growth of demand for private healthcare, and that really impacted non-GP specialists more than GPs. And then also right now, in this year, we've also got, partly related to all of that, but new things as well, like the war in Ukraine. We have many current fiscal and economic pressures and uncertainties. Inflation's rising, interest rates are going up. There's pressure on wages, which can all influence the cost of running businesses in Australia. So there's still a bit of uncertainty going forward. So how have private medical practices been responding to these pressures, and particularly the most recent pressures? Well, the first thing is that this is data from Department of Health, which shows the percentage of all doctors in private practice who are in group practice. Now, of course, for GPs who've been in group practice for years, they're close to kind of 90% of GPs in group practice. But non-GP specialists they're really catching up and forming group practices. We don't know much about the size of these practices. There's really no data on that at all, but at least we know the proportion of doctors in private practice who are in group practice, and that's been growing particularly for oncology and dermatology, and other specialties as well. So in one sense, bigger can be better. It's more efficient. You can share fixed overheads and costs like that, and that's important. But how big is important, because too big can be a problem. Too big, then the organization becomes hard to manage. But also in certain areas, it might reduce competition, might lead to increased pressure for rising fees, and particularly, on how these group practices are owned and managed, and what the incentives are there, and we don't know much about that. So, what's the optimal size? How big can these non-GP specialist private practices get? So that's the first kind of observation from the data. The second observation is that this shows just the participation of non-GP specialists in the private sector compared to the public sector. And we can see that on the left, that the percentage of total clinical hours spent in private settings, and this is up to 2020, so it's not too recent, has been falling a little bit over time. And so for 7 years, these are quite small percentage changes in the falls in the total clinical hours spent in private settings. And on the right there, we can see that the average hours spent in private settings by doctors has fallen as well over that time. And, a 3-hour reduction per week is like a morning session that's changed. And this is against a backdrop of falling hours for all doctors, men and women, over time. And so this just shows that where doctors do choose, where non-GP specialists do choose to reduce their hours, they're more likely to do that in the private sector than the public sector. And of course, this may have changed since COVID. We don't know, but it's an interesting trend nevertheless. So although more doctors are in the private sector, they're spending less hours there. So trends in the number of medical businesses is another issue which really has been a bit difficult to kind of capture. We're really not very good at counting things. We can count the number of doctors, and on the table on the left, we can see that top line is data from the Department of Health on the number of doctors, GPs, and non-GP specialists. We're much less good at counting the number of practices, and by practices, you kind of think of a physical building that the GP sits in, right? But actually, they're very difficult to count. I think the Department of Health can count accredited practices. There's over 8,000 total practices, but that number, there's only a couple of years that number's been published. There's no long-term trends on this, which is quite concerning. But then again, what we're looking at in this particular report is businesses, which is different again. On the right, we can see that one family practice, the Smith family practice, can have multiple businesses associated with that practice. Each GP may be a sole trader, and they may contract with the practice. The practice itself may be a private company or a partnership. And the directors, depending on how they take the money from the business, they may also be sole traders, or they could pay themselves a salary. So there's quite a lot of complications of how we count businesses, but we are counting businesses based on the ABN, the Australian business number. That's what we do. Now, what we can't do in this data is try and map out what a practice is. So we can't look at the relationship between these ABNs very well in the data. And that's a particular drawback. But certainly this is the first time that this data has been available. And this data is from the ABS, from the BLADE data set, which is the Business Longitudinal Analysis Data Environment, which is a data set of every ABN in Australia, every business in Australia and their characteristics. So we can see going down that, the table on the left does show we can count the number of private companies, the number of partnerships and trusts. Employing businesses is something else. So employing businesses, they're businesses which predominantly probably aren't sole traders, but they're businesses which are registered for GST and employ some staff. So that some of the data that we're looking at is just for employing businesses only rather than all businesses. So we can see there that, rough estimate of the number of business entities per practice is 6.4 ABNs per practice for in the GP world. And each GP is associated with almost two ABNs, if you like. And we don't, for non-GP specialists, we don't know anything about the number of practices really, other than the number of doctors in private practice. And so it's harder to kind of capture that. But so that, that gives an idea of the data that we're using. And then it's not practices, it's businesses, which is a little bit different. But hopefully a lot of the data that we present does mirror other data that we have from the perspective of individual doctors. Okay, so this is just the growth in the number of medical and non-medical businesses, just to give you an idea of this compared to other types of business. So we've included there finance, lawyers, accountancy, agriculture and construction. And we can see that certainly the number of the percentage growth over time in the number of specialist businesses trumps everything. GPs are next off the rank, followed by lawyers and accountancy, and then construction and finance and agriculture is not doing so well. But again, this just shows the overall trends in the number of businesses over time, which is important context. And again, this in itself reflects the healthiness, the relative healthiness of these sectors. For doctors' businesses, if we look at difference between sole traders and private companies and other entities here are partnerships and trusts, we can see that this growth is really dominated by sole traders. So every GP and specialist that enters private practice will get an ABN, and so this is largely the sole traders is largely reflecting the number of new doctors coming in. So it's more related to individual doctors, and that's where the largest annual growth, average annual growth is per year. And it's high for specialists again, non-GP specialists again, which again reflects the growth in doctor numbers. Interestingly, the growth in private companies is been 1.4% per year for GPs, but it's double that for non-GP specialists. As we've seen that there's more non-GP specialists in group practices, and the growth in private companies is more than it is for GPs. And But also, surprisingly, that there's still growth in these other entities, so partnerships and trusts, which are more complicated business entities, have more different kinds of tax rules and things like that. So, the choice of which business entity you go for when you go into private practice is quite important, and depending on your circumstances and the nature of the business, each business entity will have different benefits and things like that to you financially and otherwise. So what about the financial health of businesses? And for this analysis, we're really looking at these employing businesses, those who are registered for GST and which employ some staff. So this is a comparison of profits per business. Again, in 2020, 2021, on the left, we have just a numerical value of the median gross profit per business. This is before tax. And these data are reported in business activity statements provided to the ATO, which ask essentially for a total amount of turnover and a total amount of cost. And the cost is divided into staff costs and other kind of equipment costs. So it doesn't include the cost, don't include medical defense and things like that. But we can see certainly non-GP specialists have the most numerical value of profits per business, but also the most profitable. On the right-hand side, we have gross profit margins, which is the percentage of profit over turnover, and that again shows a more general issue of how much of the turnover goes to profits across these different businesses and compares it to the different businesses as well. So again, the doctors' businesses remain pretty profitable compared to these other businesses, at least in this financial year. But we want to dig down a bit as well, and this again looks at the median gross profits for GP, non-GP specialist businesses over time. And again, numerical value not adjusted for inflation or anything. So we can see that for non-GP specialists, they've had a lot higher growth in profits over time. And for GPs, they've had much lower growth in profits. And if you adjust for inflation, those lines will kind of pivot down a bit. So for GPs, it's been pretty flat over time. And remember, I think these when I say profits, these are often earnings of doctors, obviously, that kind of pays the household bills. So again, breaking that down a little bit more, we've got these gross profit margins. Profit as a percentage of turnover, and again for GPs, it's been pretty flat at around 38% and falling over time, and for non-GP specialists, slight increases, but also pretty flat over time. So the capacity of these businesses to make a profit has been pretty kind of constant, I think. Now we want to break this down into costs, because profits, we're calculating gross profits by subtracting costs from turnover, and turnover is essentially revenue from fees. And the top line here is for non-GP specialists, and this is their turnover over time. Below that, we have GP turnover, and at the bottom of the chart, we have costs. And again, these are predominantly staff costs, but also costs related to kind of equipment and supplies. And we can see that GP's costs over that whole period have been growing by about 2.7% per year on average. And we can see that obviously, GP's costs are higher than the costs of non-GP specialist businesses. Interesting to speculate on why that might be. And turnover is also lower as well for GPs, reflecting the difference in profits. So again, this is the first time I think ever that we've had national data on the cost of running a medical practice. Okay. Now, what about the impact of COVID? Clearly, that's had a significant impact in many ways over the last few years, and in many ways its impact is still affecting us all. And I just want to look at first of all, the number of entries and exits of medical businesses. So these are new ABNs, and essentially ABNs which cease to exist in the data that we have. And remember, certainly in 2020, we did another ANZ report on which was a survey on the impact of COVID in that first few months of COVID. And there was lots of self-reports about significant drops in number of patients seen and revenue. And here's some real data on what happened. So we can see that the top line, this is for GP entries, so the entries of new ABNs into general practice, new businesses, and that fell by 7.6% over those 2 years after after 2018-19, the first 2 years of COVID. GP exits actually fell during that first year, and we can think, and that's kind of might be surprising. People were thinking, well, actually, a lot of GPs might be going out of business. But remember, that time we had funding for telehealth, which did actually, maintain the use of at least the quantity of utilization over time for GPs. But we also had practices being able to access JobKeeper, which supported staff. So again, that could actually have delayed the exit of some businesses who may have been planning to exit anyway. There might be GPs retiring, might have decided to stay on for a few more months, or just generally stopped businesses from failing. So essentially, that had an important impact. But again, the difference between those two suggests that there's still net growth in the number of GP businesses over time, even though, and that just reflects the fact that although entries fell, the rate of exit of entries, which is bad, the rate at which entries fell was lower than the rate at which exits fell. And for non-GP specialists, entries fell by a little bit, and exits again fell by some more. So again, that just gives us a picture of what happened in terms of businesses, and also the long-term effects of this. If people were putting off decisions to exit or enter, data after this period that we have would be interesting to look at as well when we get it. Again, you've seen this chart earlier, but just focus on the right-hand side of it, what happened during COVID. So again, we know that generally use of healthcare fell initially and then bounced back. And this is certainly the case for non-GP specialists, where there was closures, suspension of a non-urgent elective surgery at various points throughout the pandemic. And that initially did affect them, but certainly profits have bounced back, reflecting increased activity from this pent-up demand of people who've been delaying their care, and that's what that is reflecting for GPs. Again, profits initially fell a little bit and then started to increase again as people came back. So that's again reflecting new data, reflecting something that we already knew from the Medicare data. Again, gross profit margins, they have been pretty flat and have fallen since COVID. Again, more so for GPs. So generally, about all of the GPs have been certainly more adversely affected than the non-GP specialists, and that's important to kind of think about as well. And again, let's look at how costs and turnover changed just after COVID. So for non-GP specialists at the top there, we can see that turnover increased by 5.8%. For GPs, it increased by 5.3%. So again, we're looking at support from telehealth and JobKeeper, and demand recovering certainly after COVID. But costs increased. So over a 2-year period, costs for GPs increased by 8.3%, which is compared to the long-term trend we saw earlier was about 2.7%. So the rate of growth of costs has increased a lot. And as I said, and also for non-GP specialists, as I said, going forward, will that continue? Will it bottom out again, given these potential increases in costs from inflation and interest rates and wage growth? So that's another thing that we will look to see. So just to conclude then, I guess overall, putting this data together has been quite revealing, and it's been a good thing to do. But we've certainly shown that, non-GP specialist private medical practices, there's more consolidation there over time. That can be a good thing initially, at least, but if they get too big, that could be an issue as well. And that's something that we have to monitor, I guess, and look out for, because this is new for a lot of these doctors to go into group practice. The effects of COVID-19, at least on profits, seem kind of temporary. There's a lot of bounce back, but we see also that costs have increased significantly, especially for GPs. And will that continue? We know that, I think what this data doesn't show is heterogeneity. So we're just looking at averages across Australia, and this data is not inconsistent with other reports that GPs in some areas and in some circumstances aren't doing very well at all, particularly those who have traditionally bulk billed. But we haven't been able to drill down to different geographic areas yet with this data. But that's something that we do want to do, to see, well, what's the variation across the sector. So future implications, well, I guess, we're still in a period of buoyant demand post-pandemic. That's still keeping turnover and revenues high. For non-GP specialists, the consolidation is something which is quite a probably major structural change in how these businesses are run, and that can have implications for fees that are charged, out-of-pocket costs, and choice and competition, and how these businesses are run is important to kind of think about. And also, I think, there are issues about how we're going to cope with these cost pressures, which still may be happening, whilst trying to maintain access for patients. This is a special issue for GPs who are, a lot of GPs really want to bulk bill patients, particularly patients on low incomes and patients in vulnerable groups. And how do we maintain access with increasing costs, as well as increasing turnover? So I think those kind of things are a real challenge for how to manage these things going forward. So I'll stop there. Thank you. Sharing my screen, and I will hand over now to Julie.
Fantastic. Thanks, Anthony. I will also just share my screen. Right, that should have come through now. Fantastic. Good morning or good afternoon. Just a disclaimer this afternoon that my presentation is general in nature, but we will run through what we are seeing in the marketplace. So similar to what Anthony was just talking about, we are seeing patients come back. Patients who may have delayed their care are coming back for their treatments now, and they have more demands, I suppose, in line with those increased costs that Anthony again spoke about. We are seeing significant wages increases and demands for more wages. Increase in aggressive patients, which the doctors are finding tricky to navigate, particularly for front practice managers and your front end staff. We are seeing a reducing number of GPs, particularly some anxiety around payroll tax. You may have heard the cases recently in relation to payroll tax. I will touch on that shortly. Demand to buy into practices. We are seeing more group practices, or doctors joining, specialists and GPs joining practices, existing practices, or setting up on their own. And then the banks are willing to lend in this space, which is fantastic. We are also seeing staff shortages, difficult to recruit and retain staff, not only your front end staff, but also particularly in the GP space, attracting quality GPs to the practice. I have seen move from the more bulk billing to mixed billing or private billings. We are seeing those percentage of private billings increase. Workplace stress and conflict, I suppose, coming out of COVID or around COVID, which has also led to doctors' fatigue and burnout, and the realisation that we need to focus on the business. So focusing on the business, we've talked a lot today about the financial side of things, which we tend to see as a lag indicator. The other areas of the business, what we call the corporate platform, are lead indicators. So we're looking at our patients and what that patient experience looks like. We're looking at our people, our doctors and staff. So how are we retaining doctors? How are we attracting new doctors? How are we retaining the staff we've got? What does that look like with the additional wages increase and wages demands and flexibility that employees are now requiring, particularly coming out of the last couple of years. Services and innovation, one of the things that's in the report that Anthony did mention about was services and innovation, and we're looking at technology and how technology can be used within practices from both GPs and specialists. And then in terms of processes and facilities, we're looking at what sort of efficiencies do we have? What organisational changes or management changes do we need to look at? So when we view the practice as a whole, we look at the patient experience, the people, the processes, the services as our lead indicators, which will then have an impact on what our financial indicators are. And the last issue I will briefly mention this afternoon, is payroll tax. So payroll tax is a state-based tax, and it is administered by the Office of State Revenue in each state. So it's not a Commonwealth tax, it's not administered by the ATO, but payroll tax looks at the payments to employees, so wages, superannuation, and payments to eligible contractors. And that payments to eligible contractors is where we're seeing a lot through the media. You would have heard of cases, the Optical Superstore, Thomas and Nas. So payroll tax isn't a new issue, but we are hearing a lot more about it and seeing a lot more activity in that area. So there are a couple of factors that are making payroll tax such an issue. So the first one is the pandemic and the scale back of audits. So during that time, you'll note that we did have JobKeeper and cash flow boost and those sort of incentives coming through for businesses, and we did see the scale back of payroll tax audits during that time. So I'd say it's just been put on pause or on hold for a period, and now activity seems to have started again. There's been some recent cases that you'll no doubt heard through the media, Optical Superstore and Thomas and Nas, which has brought this to the forefront. And then doctors sharing information on platforms. So we're seeing doctors within WhatsApp group or private Facebook groups, those sort of things, or other online forums where doctors are sharing more information about what they're seeing in practice in relation to payroll tax. So it's certainly an area of focus and something that we will need to look at, and I'd certainly suggest having a look at that if you haven't addressed that within your business as yet. I will now stop my screen share and I will hand over to Dr. Michael Wright. Hopefully I can do that.
Thanks, Julie.
Thank you.
Thanks, Julie. And look, thanks, Tony. I really enjoyed reading the report, and I'd congratulate you and your team on this important piece of research. I mean, it's really helpful to see some analysis of what's going on in private practices. They're often overlooked in health reform and health funding discussions, so really helpful to see. And some of the findings certainly reflect what we've been seeing affecting GPs, non-GP specialists, clinicians, and also practice owners. I was particularly interested in the ongoing disparity in profitability between GPs and other specialist practices. I think that's been thought to exist, but it's great to see, well, very interesting to see that confirmed. And I was fascinated to see the very slow decrease in profit margins, particularly for general practices over the last decade. Many of your attendees may have seen there's recent data showing that there's a workforce crisis in general practice, and less than 1 in 8 medical students are choosing to go into general practice. And I think this profitability disparity is going to be one of the main contributors to that. I was also really interested to see the data about increased consolidation and corporatization of practices, and seeing that's picking up in specialist practices, but slowing down for general practice. And I agree with your interest in trying to understand what's the optimal number. As you pointed out, if you get bigger practices, they might be more efficient, but that might reduce competition. And the evidence shows that patient satisfaction often decreases once you get above a certain size in a practice. Through my RACGP and event work, we've been hearing a lot of increased concerns about decreasing practice viability. And I think you've highlighted that with some of the data in the last year. I'm also interested to see what happens in the next year as we get more data around the COVID vaccine rollout. So the Medicare numbers for those needed to be bulk billed and were a relatively new rate, a relatively low rate. So I'll be intrigued to see in next year's data if you see that the decreasing profitability, decreasing activity, but increasing costs, perhaps leading to more exits from the GP sector. And I think my final point was just to say that you've really highlighted the paucity of data that we've got to understand what's going on in private practice medicine and how important it is that we get some more data. I think what you've done is really innovative, and I look forward to seeing more BLADE data, but I think it's important that we actually get better data to understand the activity and profitability of private practices and then to understand their viability. So thanks for your work on this.
Thank you, Michael, Julie, and Tony. That was exceptionally insightful. We do have a few questions that have come through the Q&A, and just a reminder for those on the webinar to please post anything you'd like to ask our panelists this afternoon. I might kick us off because I've been taking a huge amount of notes myself. So I think the first one, obviously we've touched on, you know, the gross profit margins slowly decreasing over time. And I mean, it's, you know, quite frightening to see that they're well below the inflation rate. So not only do we have, you know, seen the increase in costs in terms of the consolidation of the sector and what that means for running much larger practices, especially as a GP practitioner. But, you know, we're facing into economic increasing prices, regardless of also the staff costs that Julie touched on. So my question would be, you know, and Julie, is probably one for you because you touched on it to kick us off, and then I'm interested to hear any other views. But you touched on, you know, services and innovation and how our practitioners can reduce the cost in their practices, because obviously some are fixed, you know, rent or, you know, paying the bank if you have a mortgage on your commercial property. So what kind of ways, if we are looking at bigger medical practices, whether they're GP specialists or non-GP specialists, what are ways that we can think about getting more revenue generation into those that are lower cost?
Yeah, fantastic. Thank you, Cindy. Good question. So the costs that we are looking at, the biggest cost that we have for practices that we're seeing is wages, superannuation, recruitment costs, and rent. By far, they're the bulk of what we're seeing is the largest expenses there. But how can we, I suppose that's a defensive mechanism if we look just to how do we reduce costs. What we should look at is how we can increase the top line revenue. So we saw some of the graphs that Anthony showed us before in terms of how that revenue is looking. So what we're seeing, or what I'm seeing in the industry, is moving more into specialisation. So even in GP land, we'll call it, moving into, you know, do we have a skin specialist, or do we have weight loss, or some sort of, what are we known for, I suppose, within those, within our area, to be able to increase our top line. So the other thing we're seeing is the movement away from, that's a sensitive topic, moving away from bulk billing. There will always be a sector that we need to consider for bulk billing, but I am seeing more mixed, for GPs particularly, moving away from that bulk billing into the mixed, or some practices are doing purely private billing. So in terms of offensive, what can we look to change is what are the drivers, what can we look at for that top line? So is it the way we're billing, what we're billing, the services that we're offering, and the type of services each of our doctors are offering, I suppose.
Thank you, Julie. And that's a really good segue to the question around that we have from our audience about what are the largest implications of GPs not being able to bulk bill going forward, and who are the most effective and what can be done. So is there anything else you'd like to add in that regard?
Yeah, great question. So I think talking to our clients and GP practices, what we are seeing is that there will be a sector, or there'll be a need for a sector that that do need bulk billing. particularly in rural areas or those who just literally can't afford to go to, be privately billed. So there is a sector that will need, there's a need there for bulk billing. But what I'm seeing is some practices are considering, who do we keep the bulk billing for and who do we move to private billing for? So sort of segmenting their patient base and seeing how they can move to a mixed billing while still being able to maintain the patient care at the level for those who do need that bulk billing.
Thanks,
Cindy,
Judy.
I could jump in there if you like. I mean, I think putting my sort of RACGP hat on, I know we've been doing a lot of work to try to support practices to understand what their practice costs are, and that if bulk billing is unsustainable, in order to keep their business going and providing any service, they need to move to a mixed billing model. So we're seeing that more and more in that if you ask GPs who do you bulk bill, they predominantly bill concession card holders, children, people with disabilities, people in nursing homes, and people with multiple chronic diseases. And they're the people who do need bulk billing, but the current Medicare rebate isn't adequate for many of them to continue doing it. So I think the solution for many practices is they're private billing those who can afford it, but they're getting increasingly desperate as to understand, how can they manage to keep bulk billing the people who they do.
Yeah,
and I think it's also to do with the model of care that's being provided, the private practice model. It's kind of just the way it's set up. It's a dominant model in Australia, and obviously in rural areas they're slightly different models. We'll have community health centres in Victoria, state-run kind of thing, where the state's put in money as well. So it's kind of, we've got to really think, if we want to guarantee access to vulnerable populations, we need to think of a different model, I think, as well. So I think that's another thing that we need to begin to think about.
Thank you, Tony. Michael, I might go back to you, just keeping on the theme of keeping on the same theme. So the question we have here is, what is your view on the current discussions around reducing Medicare rebates in this environment where practice running costs are increasing? And do you see any negative impacts with private versus bulk billing in the future?
So I'd be concerned if there was any more reduction in the bulk billing, in the funding for bulk billing. So I think the rates of bulk billing are likely to continue slowly dropping, particularly because it's been artificially elevated for a couple of years because as I mentioned, the COVID vaccines needed to be bulk billed. And so they were elevating the figures. So as we get through the COVID vaccination program, that will in itself reduce the bulk billing rate, and then the shift to private billing will also do that further. And I think what it does is it just places greater pressure. I think we acknowledge that maybe there are some patients who can afford to contribute to their care, but it's not a long-term solution for the health system for us to shift the burden of funding back onto patients. That there needs to be some other models, and as Tony's mentioned, other funding to practices to support their infrastructure, and then certainly other funding to support practices who do choose to bulk bill certain patients.
Thank you. Tony, I might hand this one to you. It's a question around the consolidation that we've touched on in the paper.
Mm-hmm.
Do we have any views on why non-GP specialists are consolidating their practices?
Look, I mean, I'm not sure. I mean, it could be in relation to cost pressures. I think the medical training pipeline is very competitive now. We've had a massive growth in the number of doctors over time, particularly non-GP specialists. So when they come out of fellowship and go into private practice, they're facing a very different kind of market than they did, say, 10 or 15 years ago. And that might be encouraging them to go in with somebody else in order to set up a business rather than try and do it by themselves, and maybe getting that kind of advice. So that's part of it, as well as an issue of sharing costs. And I think there are a lot of other businesses who support private medical practices and billing arrangements and administration, which mean that the doctors can focus on being doctors.
Yeah,
Anthony, I might add to that if I could. We're seeing something similar there. So what we're looking at is sometimes it's around succession planning, where the specialists are finishing their fellowships and joining other group practices where there's some older doctors who may be looking to retire in the coming years. So it's future-proofing that particular business, and also giving a bit of a footprint to, the business is established. We don't need to set it up from scratch. So there is an appetite there for specialists when they complete their fellowship to join in with a more senior specialist, I suppose, in that group practice, with the view for the more senior doctors to eventually retire. So there is that succession planning piece we're seeing around that as well.
Thanks, Julie. So the next question, and this may relate to the consolidation, but I don't want to lead the panelists. We'll be interested to hear your view. So in terms of thinking about ways to reduce cost pressures, it would be useful to understand why GP costs are higher and growing faster than non-GP specialists. So is that because they're higher in the consolidation play, or is there more to it?
Michael may have a bit of insight.
Yeah, look, I could jump in there. I think, and a couple of things. I think the income earned by each professional is lower, and the staffing costs are typically higher, in that there are more reception staff and often more nursing staff to manage the flow of patients. So it's essentially the income per patient is lower, which I'd say that's the main cost driver, as well as the increased staffing.
Thanks, Michael. I don't know if you'd know the answer to this, or happy for you to throw to another one of our panelists, but so the question from Nigel is: economic history suggests practice consolidation is inevitable, but it has access implications for small towns. Does the ACCC actively monitor medical markets to avoid anti-competitive aggregations?
I might hand that one to you, Tony. I don't know.
Yeah, look, I don't know. I think they're kind of, in the past they've been involved in particular types of medical practice, like IVF and things like that, where there's been, takeovers or mergers and that kind of thing. But I don't think they routinely monitor these things. I think the ACCC are really focused on anti-competitive kind of conduct, and try to prevent that, to protect consumers. So it's a bit different, but certainly I think how this plays out in terms of out-of-pocket costs rising, for example, which they are. In one sense, we've got for people who are charged a fee, out-of-pocket costs are rising for specialists, but also bulk billing rates are rising for specialists actually faster than it is for GPs. So non-GP specialists, they're bulk billing more than they have ever done, but where they are able to charge, they're charging a higher fee to the richer patients probably as well. So I think that's an interesting dynamic as well, where they're trying to maintain their income, but just changing the mix of billing, to try and maintain access as well. So that's important.
It's a very good question, and one to certainly ponder. I mean, certainly, our past papers that we've touched on, Tony, and it's unfortunate to see that even though there's been an increased number of doctors in our system, we haven't been able to get them into the smaller towns in regional Australia. The location seems to still be a part of that. So the question around consolidation absolutely, plays into that as well, I would imagine.
Yeah, no, that's right. And I think, how telehealth will begin to embed in practice is still a bit unclear yet, and that has potentials for efficiency savings, because you in the long term you don't need massive physical infrastructure to see patients. You don't need an office anymore, right? So, but that's a long way off before that happens. And what's the optimal kind of balance of telehealth versus face-to-face will differ across specialties, and hasn't really, found a new equilibrium yet, I guess.
Yeah. And I think, in the time that we got left, certainly this question's been voted up, and it's really good in terms of what the comment you've just made. What is the role of technology in reducing costs and increasing efficiency for both specialists and GP practices? I'd be interested in getting each panelist's view on technology in this space. Certainly an untapped opportunity, I think, for a lot of us. Who would like to kick us off? Perhaps Julie?
Yeah, fantastic. Thank you. So the role of technology is just one of those pieces of the corporate platform that I was mentioning before that we need to look at, that practices will need to embrace, I suppose. Gone are the days, 2019, where you your patient would just ring up to make an appointment and come in. So we have moved to, you know, where there's apps now where you can book your doctor, you can find it within the closest places to get your vaccine. So we have seen a huge technology shift in the last 2 years, but I think there is still certainly a greater role that technology can play, and maybe that's a little bit of a key for what that looks like in the rural areas. It's not the same, I suppose, as seeing your doctor face to face, but I think the role of technology will just continue to increase within practices, and hopefully with that increase in technology might assist in squeezing some of those other costs that we're looking at to help drive that profit.
And Michael, what are you seeing that you think could be a really good opportunity for our practitioners?
Look, I think the issue with technology uptake to date, it's often been constrained by the funding models. So I think for something like telehealth, we've been able to do that for 20 years, but doctors weren't funded to do it. So they were relying on the face-to-face models because that was how they got paid through Medicare. So I think as the funding models become more flexible, I think there will be an opportunity for increased technology uptake. But I think I think where doctors are very keen to integrate technology, but I think there's also concerns around sort of privacy, confidentiality, which we always come back to, and particularly concerned about how data is maintained. And I think that combined with the funding issues has slowed down the uptake of technology. And then I think we just have to be cautious with technology too, because it's often great for access, and there are new models for getting online prescriptions, referrals, pathology tests, medical certificates, but often they're not with your regular doctor, and potentially it's going to create more fragmentation of care. And we need to make sure that the innovation and technology supports high quality care.
Thank you. And Tony?
Yeah, look, I mean, I think technology always gives us a bit of hope, but it also costs a lot initially as well. And there's often slow uptake. It's hard to get it into workflows and to really see what the benefits are for patients and for the practice. COVID it was a kind of step change in that as well. And often you find that new technology also, you know, is adopted, you know, in the private sector before the public sector. So it doesn't really benefit vulnerable communities first. They're often the last to kind of hear about it. So that's another thing about how technology kind of rolls out, but it still plays a very important part in how practices are run. And as practices get bigger, they need to think about, okay, this is a cost, it's an investment, but what are the returns on that investment? And that's often a bit difficult to think about because there are returns to patients and access to care, and you know, financial returns for the practice as well, and saving costs in other places. So those things have got to be really clear before doctors are going to invest in this technology. But we've seen, you know, electronic prescribing and you know, billing systems and electronic appointment systems really come to fruition during COVID, and I'm not sure how that has that saved money. I'm not sure what benefits has that had. It had to happen because of COVID, and that might have led to these increased costs that we're seeing. But you know, what are the long-term benefits of that? So it's an important area.
Thanks, Tony. And while I have you, I might just ask one last question. And it's you know, thinking about models overseas or anything we can learn from other countries. Any ideas about what might be the optimal size for non-GP specialists, noting that there's no data in Australia, but is there anything from overseas that we could look at?
Look, I mean, you look at a lot of literature in the US, and medical groups are huge. There's like 300 doctors in this medical group who get paid from Assura, and they're just massive, you know. And you think, how is that organization managed? How does it work? Doctors practicing still quite independently, but part of this much larger group owned by an insurer. So those kind of models are quite different as well, and it's hard for us to kind of get our heads around them. But I think as well for non-GP specialists, you know, at the moment, you know, although they're allowed to work together in private practices, they're not allowed to collude in setting fees. GPs are, they can set a practice fee, but non-GP specialists can't. So it's because they're supposed to be, they're separate businesses, essentially, even though they might have common administration and billing, same offices. The patient goes in, they just see a group of doctors. They don't know that they're actually different businesses. So those kind of issues and constraints and those regulations around how doctors work together are quite important in encouraging or not the continued growth in group practice. And that still has implications for patients' access and how doctors can set fees and how they work together actively. So that's quite important.
Thank you so much, Tony. And thank you, Julie and Michael, for joining us this afternoon as well, and to all of you that dialed into our webinar. We have got some more questions that we didn't get to, so we'll endeavour to circulate that amongst the panelists and then email you the responses as well as the report. So the report, this is the official launch of the ANZ-Melbourne Institute Health Sector Report, so that will be sent around to you shortly. And once again, on behalf of ANZ and the Melbourne Institute, I'd like to thank you all for joining us today. Have a good afternoon.
Thanks,
Bye-bye.
everyone.